Okay, thanks, Jody. Go ahead and get started. Again, my name is Kristal Vardaman. Thank you all for joining us today. Excited to chat with you about issues around Medicaid HCBS. Okay, slides. There we go. I'm going to start off with just some background on MACPAC, who we are, and our role and structure. I'll go into some background on Medicaid HCBS. And then I'll walk through some of our recent and ongoing work, and Tamara will join me for the portion as well. We'll end with pointing you to some MACPAC resources and open up for discussion. So just to give you some background on who MACPAC is a nonpartisan, independent legislative branch agency. So we're part of a group of congressional advisory groups. So there's, of course, the Congressional Budget Office, Congressional Research Service, Government Accountability Office, and then a couple of small commissions that are focused on healthcare. So there's us, and there's also a Medicare version, the Medicare Payment Advisory Commission. So MACPAC's job is to provide analyses and advice to Congress, the Secretary, and the states on Medicaid and CHIP policy issues. We produce reports annually in March and in June, as well as issue briefs and other publications throughout the year. We also provide technical assistance to congressional staff as they're working through, for example, draft legislation. They may come to us with questions on background or making sure like what they're proposing to do is likely to do what they want it to do and what some of the effects might be on stakeholders. And we also see ourselves as serving as an information resource to the broader health policy community, producing resources that hopefully people find useful, and also, of course, talking to groups like yours about Medicaid and CHIP policy. The commission itself consists of 17 commissioners who are appointed by the GAO to 3-year terms. The commissioners are a wide range of healthcare stakeholders. We have a number of former Medicaid directors, people who run health plans and health systems, beneficiary advocates, providers, researchers, and other stakeholders. And so they meet in public session about 6 to 8 times per year in person, sort of before the pandemic, and right now virtually, to talk through different issues. And as a permanent staff, Tamara and I and our colleagues work throughout the year to produce the analyses that we present to them so they can discuss and come up with recommendations to Congress. And the commission just passed its 10-year anniversary. A few years ago, we began our work in 2010. So again, we do produce mandated reports to Congress in March and June. Many times they contain recommendations, although some are also descriptive. We produce fact sheets and issue briefs. We also contract out some of our work, which we'll talk about some of our contracted work as well as internal work shortly. We produce a data book called MACStats, which has lots of information on Medicaid spending and descriptions of beneficiary characteristics that serves as a resource for the policy community. Similarly, we have a data book on duly eligible beneficiaries, which is something we do jointly with MedPAC, the Medicare group. And we also produce a lot of state policy compendia, which basically compiles a lot of information on how states approach different payment policies. We have one specifically focused on state HCBS waivers that we'll mention through this presentation. Again, these are things we think are resources for the policy community and hope people find helpful. So now I'll turn to walk through some background on Medicaid HCBS before going into some of our recent work. So Medicaid home and community-based services are services that allow people with physical and cognitive limitations to live in their home or home-like settings and to remain integrated with the community. So HCBS encompasses a wide range of services, including personal care services, support and employment, home delivered meals, a wide range of supports. And state programs, state Medicaid programs vary considerably in how they structure their HCBS programs. We often say if you've seen one Medicaid program, you've seen one Medicaid program, and that's very much true, particularly when it comes to HCBS. There are certain HCBS that are covered in the state plan and are available to anyone who qualifies for Medicaid. There's also a number of waiver authorities, such as the Section 1915C waiver authority that states use to provide HCBS, but are able to have some flexibility to forego certain Medicaid requirements. So for example, the 1915C HCBS authority is one that lets states cap the number of people they serve and therefore have waiting lists for services, which wouldn't be something possible for services in the state plan. And many states, most states really use some combination of state plan and waiver options to kind of complete their HCBS delivery system. So rebalancing long-term services and supports away from institutional services and towards HCBS has been a federal and state goal for decades. This is, of course, something that has followed the Americans with Disabilities Act and the Olmstead decision. So federal policy and states have been working, over several decades now to serve more people in their homes and in the community. One of the common measures of rebalancing is the proportion of LTSS spending that is for HCBS. And since 2013, Medicaid programs have spent more on HCBS than institutions overall at the national level. And now I think the most current number for 2018 is about 56% of LTSS spending in Medicaid is for HCBS. And so this map gives you some of the most recent data that we have that CMS has published on, again, the proportion of LTSS spending that's for HCBS. You can see here the dark blue states are those that are spending 75% or more of their LTSS spending is in HCBS, and the light green are states that are under 50%. In this particular map, Illinois, we don't have data for Illinois. Looking back at the report, all of the states that are in gray here are ones that have managed LTSS and didn't report enough data for the evaluators to put that information in this most recent report. The last information we have is from the 2016 report, in which Illinois was just under 50% of LTSS spending being for HCBS overall. And so you can see it was kind of in the, with the current numbers around 56%, just below the average. And we've done a lot of work, which we can talk about some of those states that are at the lower end, which we'll get to shortly, and also understanding some of the innovations and things that states, various states across the board are putting into place. So that was the variation across states, but there's also variation across populations. And so while at the national level, again, about 56% of spending in LTSS is in HCBS, spending for people with IDD is actually much more rebalanced than for some other groups, for older adults or for people with mental health or substance use disorders. Some of this has to do with, the Olmstead decision and settlements and the closing of institutions over the years, the movement for more community living. There is some variation across states in this number, which is something that we've also tried to take a look at, why some states are more successful than others in serving people in the community. And again, as rebalancing has been a federal and state goal, there's been a number of programs the federal government has put into place and to support states. Some of this has come in the form of enhanced funding. So the Balancing Incentive Program was a program that supported states in developing an HCBS infrastructure. The Money Follows the Person program has supports states in transitioning people from institutions to the community. And COVID relief funding has provided, enhanced funding to support a number of activities. Most recently, the American Rescue Plan Act has provided states with funding to do a lot of things that we're looking into in terms of supporting the HCBS workforce and providing a number of different additional forms of assistance. The federal government has also done guidance and technical assistance for states. So for example, about half of states at this point have managed long-term services and supports, which can be a way to promote rebalancing. And so CMS has put out some guidance there. There's also been a number of technical assistance programs through the Innovation Accelerator program. So ways for states to get together and learn from CMS and its contractors and talk to peers as they work through different challenges. And CMS also published a rebalancing toolkit that covers the variety of authorities that are available to states for HCBS and different kinds of activities that they could be undertaking as they try to shift their systems. And we also did some work, and I wanted to point out before we get into some of the things we're going to talk about in more in depth on HCBS waiver waiting lists. So again, while Medicaid spending for people with IDD, which I know is the focus of your group today, while it's primarily for HCBS, the share does vary by state, and people with IDD are the largest group on HCBS waiver waiting lists. Again, those section 1915C and section 1115 demonstrations allow states to put in place waiting lists. And in Illinois, 2018, according to a survey, there were over 19,000 people with IDD who were on waiting lists for HCBS services. Tamara and I did some work on how states manage their waiting lists, understanding that states, have different strategies and how they set up their waiting lists, depending on, how they want to try to use their limited resources. And so there are a few federal requirements for how they manage those waiting lists. So we went through the waiver documentations and talked to states to understand how they manage their waiting lists, why they've chosen the mechanism they use, and how some states were able to reduce or eliminate their waiting lists, like what their strategies were, what kind of investments it took to get there. And so we just wanted to point out that from that review of waivers, we did see that the Illinois waiver for children with IDD, which does have a waiting list, uses a combination of priority and wait time. So priority-based waiting lists are those that prioritize based on need, and wait time is usually like a first come, first serve, and states choose those for different reasons. Priority means you can serve, people with the most intense needs first. Wait time may mean you can serve more people because you're serving people with different levels of need at the same time. And usually a combination means that states are kind of bucketing out people into groups, but then perhaps within those groups, ordering it by wait time. So that's a combination approach. Pause here and ask if there's any questions before I move on to our next section.
I have one question. I'm curious if other states like Illinois, who I think manage their wait list with the Ligas lawsuit, are other states involved in lawsuits that manage their wait lists?
We didn't look at that particularly in regards to the waitlist issue. I mean, we have heard that a number of states have, whether it's an Olmstead settlement agreement or again, the variety of litigation that certainly plays a role in, a number of policies around HCBS and how much states are pushing rebalancing because they have to due to some settlement agreement. Any other questions?
Thank you.
Okay, I will move on then to our next section, which is we're going to walk through 3 different projects that we've done over the past couple of years around rebalancing and workforce support. And so starting off with this section on barriers to and support for rebalancing, coming out of the last section. So again, we contract out some of our work. And so this is a project that we worked with RTI and the Center for Healthcare Strategies on. And this project was exploring the factors that have limited rebalancing in states where HCBS spending is below 50% of total LTSS spending. So states like Illinois that are, more on the lower end. We wanted to understand were there particular issues in those states, particular challenges that those states were facing that the states that we often talk to who are kind of in the higher end, the states like 75% and more, are there unique challenges for these states? And how can the federal government further support these states in trying to serve more people in the community? So we've chose 5 states. So Louisiana, Mississippi, New Jersey, North Dakota, and West Virginia were the states we talked to. And the contractors did 28 structured interviews, tried to do around 5 in each state to get a broad range of perspectives. So they were talking to state officials as well as the beneficiary advocates in those states, provider organizations, and other experts, as well as federal officials and other researchers. So in terms of themes, although we were looking at states that were on the lower end, I mean, each of the study states was doing something. They were, maybe they were participating in balancing incentives or money follows the person, and they all had something underway. So it was something that, while they, have struggled to serve, more than the national average in the community, they all had some investment underway. And so, several noted that money follows the person and balancing incentives were important by providing support, both, financial as well as technical assistance for their HCBS infrastructure. And in states with managed care, and this kind of goes not just the study states, but across the board, there are often incentives built in to support transitioning people from institutions to the community or diverting institutionalization. States usually use what's called a blended rate. And so if plans are able to serve more people in the community that was built into their assumptions for capitation, then they are able to retain those funds and use them for something else. And so those incentives are usually built in. I will note that in terms of people with IDD, relatively few states have managed care for the LTSS services for people with IDD. A lot of states still have their LTSS for people with IDD and fee for service, and where they have managed care programs are often focused on older adults and people with physical disabilities. So themes in terms of barriers to rebalancing, one of the takeaways from our work was, again, we focused on states that are the lower end of rebalancing, but found that a lot of the challenges that they raised are common challenges across the board. So first, structural bias in Medicaid toward institutions. Nursing home services in Medicaid are mandatory. Just about every state, I think every state covers institutions for people with IDD. However, HCBS are optional benefits and often administered through waiver programs, meaning they can have waiting lists. And so, the lack of, guarantee for access to HCBS is considered a structural bias in Medicaid toward institutional care. Also, constrained state capacity for HCBS administration is something that we hear across all states. So people who are responsible for the HCBS programs are often the LTSS divisions that are also responsible for institutional services. They're often the same groups of folks who are responsible for integrated care programs that serve dually eligible beneficiaries. So they're having to understand how to work across Medicare and Medicaid policy. And of course, turnover in state staff, constrained state budgets, all of these are things that limit states' ability to develop, start up, implement new HCBS programs. And so that's something that we often hear. The next two, a lack of affordable and accessible housing, as well as persistent workforce shortages, are two things that come up in virtually every project that we work on. Lack of affordable, accessible housing being a big constraint to get people in the community and keep people in the community. And workforce shortages we'll talk about a bit more in depth later on, but it's something that all states are struggling with. We've been doing some work looking at state ARPA plans, so how they're going to use new funding that they've been given through COVID relief, and almost every state has something underway around workforce. So we'll talk a little bit more about that as well in a few. States with relatively low levels of rebalancing also face a couple of challenges that we thought were worth calling out that were somewhat unique to them, not entirely unique, but things that seem to be particular issues there. One being a lack of executive and legislative champions, that being something that stakeholders felt was really necessary to promote HCBS. And then second, the strong political clout of the nursing home industry being a big factor. So things like the influence of provider taxes and a resistance to change there was something that people felt was a barrier to rebalancing. And in terms of opportunities to support states rebalancing, interviewees said there were a couple of opportunities. Implementing presumptive Medicaid eligibility for HCBS, really trying to shorten the time it takes for people to become eligible or to be found eligible. Making programs that support HCBS, like money follows the person, permanent, assisting nursing facilities and other institutions in diversifying their services, things like adult day programs, for example, creating other alternative housing settings to, again, try to get through some of the availability of housing issues and supporting the workforce development. We also talked to them at the time around the lessons they were learning during COVID, which of course had created additional challenges, including more workforce shortages, exacerbating them in some cases, increasing social isolation for beneficiaries being a challenge. There was been some federal flexibilities that were helpful and highlighted innovations like assistive technologies that people found useful, but also heard from folks that virtual service delivery has limitations, so that there are things you can only see if you're in someone's home. And so wanting to return to in-home assessments and things was one thing that we heard as well. And I'm going to move on, but again, first, just want to pause and see if there are any questions on that section. If not, I can just move on. The next section is around work on how Medicaid serves people with IDD. And this was a contract that we did with Health Management Associates. And so they did a broad range of stakeholder interviews to understand how Medicaid programs serve people with IDD in a number of different dimensions. So we wanted to understand, for example, how person-centered planning and self-directed services work, what kind of supports are states providing to families and caregivers, and also gaps in access to clinical services. So of course, we know that people with IDD are a diverse group, including a wide range of age groups and a wide range of healthcare needs. The services that are offered to people with IDD vary, of course, as well, including across their lifespan. Can include things like school-based supports as well as behavioral health services. We indicated that more research and data are needed to look at disparities for people with IDD who belong to racial, ethnic, and linguistic minority groups. Some of the data that we have points towards some potential disparities and suggests that there's more culturally responsive supports and services that are needed. So when it comes to challenges to serving people with IDD through Medicaid, again, I'll call back to the waiting list discussion. So while there's policies that have expanded access to HCBS, waiting lists exist in many states. Again, the workforce shortages, and not just the direct care workforce shortages, but also a need for physicians, dentists, behavioral health providers, and others who can meet the needs of people with IDD. And of course, the COVID pandemic has posed a high risk for people with IDD and even greater risk for those who are people of color. In terms of trends in service delivery, some of the things that we looked at were around person-centered thinking and planning in services for people with IDD, particularly around self-directed service delivery being a growing trend. And one of the things that states and stakeholders are looking at and promoting are ways that people can be supported in managing their services, that they have the advice and the resources that they may need to manage a service budget, managing hiring their own staff and things like that. And states are also increasingly supporting families, including siblings, particularly as we see some older caregivers aging, more support from siblings. And we wanted to also just highlight in particular, one of the things that we looked at was meeting behavioral health needs of people with IDD. So nearly half of people who receive IDD services have a diagnosed co-occurring mental health condition. And this comes with higher rates of institutionalization and more adverse health outcomes. But also that people with IDD need positive behavior supports even if they don't have a formal dual diagnosis. And some of the barriers that we raised in meeting their behavioral health needs include things like silos between the mental health and the DD system, and also provider inexperience in working with people with IDD. Those are things that, again, come up in a variety of clinical issues, but particularly here in the mental health space. And one of the initiatives that we highlight in the report, and we also had a panel where Arkansas has a provider-led shared savings entity, which is an effort to serve people with dual diagnoses in a system where it is through kind of fee-for-service and not a managed care system. And so that's something that other states could look to as a model. And before I move on and turn it over to Tamara to talk about workforce, wanted to see if there was any questions here. And there'll be time for questions at the end, of course, as well. Okay. Okay.
Sorry,
Go
I have
ahead.
another
Sure.
question. I'm just curious, when you are showing some of the barriers, you indicate that you look at maybe states that aren't doing so well in doing home-based services or using waivers, but does Illinois stack up, or do you have a statewide one where we could see where Illinois falls in using services?
Sure. So what I can do is I could pass on to Jody some materials to share with you all. Again, the most recent report CMS has out doesn't have some information on Illinois, but some of the past reports have much more detailed information on how spending in various waiver types, for example, and there's some information on like different kinds of beneficiaries in different states. So we can share that to pass along after the meeting. Okay, and I will turn it over to Tamara to talk about workforce.
Great, thanks, Kristal. So a common theme, as already has been mentioned in a lot of our recent work, has been how there's a shortage of workers providing HCBS. And Kristal mentioned just a few minutes ago about how in our recent contractor work on rebalancing, the persistent and growing LTSS workforce shortages were frequently cited as a primary barrier to expanding HCBS. And in our work on HCBS waiver waiting lists, stakeholders suggested that even if waiting lists were eliminated or reduced, there may not be an adequate provider capacity to meet that increased demand for HCBS. So we held a panel at our October 2021 commission meeting on this issue, which included state staff from Arizona and Washington. And so I will briefly mention some of the innovative things going on in those states, as well as others throughout my remarks, but you can find the full transcript from that panel on our website, and the link to that is included in the resources at the end. So we use the term HCBS workforce generally to encompass the direct care workforce, which is made up of personal care aides, home health aides, and certified nursing assistants, as well as independent providers who are individuals that are employed directly by beneficiaries through consumer direction, and direct support professionals, which are workers who support individuals with IDDD. This workforce is largely made up of women, people of color, and is low income, including many that are on Medicaid themselves. And the shortage of these workers is due to multiple factors, including low wages, limited opportunities for career advancement, and high turnover. And states have been working to address these issues, and many plan to use funding from the American Rescue Plan Act to invest in this workforce as well. Next slide, please. So in 2020, the median HCBS worker hourly wage was about $13 per hour, with state medians ranging from about $9 to $15. And the median annual income was about $18,100, which was just over 100% of the federal poverty level for a family of two. The median wage for direct care workers is often less than that of jobs with similar entry-level requirements, such as retail, housekeeping, and customer service. And rates for HCBS are set at the state level. States pay for HCBS workers through several Medicaid authorities, like Section 1915C waivers, Section 1115 demonstrations, and state plan amendments. In 38 states and DC, beneficiaries and self-directed plans have some authority to set rates for their providers. And state approaches to raising wages and providing benefits to the workers also vary based on whether HCBS is administered through managed care or fee-for-service. One common tool that states use to raise the wages of HCBS workers employed through agencies is wage pass-through laws. Under these laws, when state Medicaid agencies pay providers more, they're required to pass on the higher reimbursement to workers, either requiring a percentage of the rate increase to be passed on or by requiring a specific dollar amount increase. And as of 2019, 14 states have wage pass-through laws in place. HCBS workers also often lack benefits like health insurance and retirement. Only 37% of workers have health insurance through their employer, and 80% do not have retirement benefits. Next slide, please. Okay. So Washington is a leader in addressing many of the issues facing the HCBS workforce. In regards to wages and benefits, their state Medicaid program provides benefits such as health insurance and a retirement benefit. And it also increases wages for all types of HCBS workers. The state has a strong union, and their wage pass-through law is negotiated through union contracts and requires that raises in pay to independent providers negotiated through the union also apply to agency-employed HCBS workers. And at our October panel, state staff shared that the minimum wage in the state has increased by 26% since July of 2018. And there's an annual inflation indicator that raises the minimum wage on an annual basis. Their minimum wage is currently at $14.49, and in Seattle, $16.69. Workers can earn more based on the setting they work in, their seniority, and their level of training. For example, after completing 70 hours of advanced training and receiving a certificate, there's an hourly pay differential. State staff, however, also shared that keeping pace with raises in the minimum wage has been a significant challenge for the state. Next slide, please. In regards to training, states set the training requirements for the majority of their HCBS workers. No federal requirements exist for personal care aides or direct support professionals. Required hours of training for HCBS workers paid through state Medicaid agencies range from 40 in states like New York and Virginia to 75 in Washington. And training can address causes of worker dissatisfaction by improving job satisfaction and allowing workers to be better equipped to manage their care responsibilities. Workers who received training through a Medicaid demonstration reported higher job satisfaction and intent to stay in their roles. 26 states require a minimum number of hours for training, and 34 require a competency-based assessment for personal care aides. And to further professionalize the HCBS workforce, some states have developed career ladders or lattices through their training programs. Typically, careers in the HCBS workforce offer little opportunity for advancement. But one potential avenue for advancement is to allow training hours to count towards a more advanced certification. For example, in Alaska, the HCBS worker training program can be applied towards a certified nursing assistant or home health aide certificate. Another approach is to provide advancement opportunities for workers to move into management roles in DSP agencies or other applicable fields like social work and case management. Training portability and the use of career lattices can also allow workers to provide care in multiple settings, such as nursing homes and assisted living facilities. In Maine, for example, the certificate that workers receive after completing their training can be used in multiple long-term settings. Next slide, please. So as one example, in Tennessee, they've developed a comprehensive training program for their HCBS workforce that is tied to a career ladder and wage increases. So in Tennessee, HCBS workers are employed through agencies that contract with their managed care plans, and the state requires its MCOs to support the development and adequacy of the workforce. Through a state innovation model test grant, Tennessee developed a competency-based training program that is tied to wage increases for workers, known as QUILTUS, which stands for the Quality Improvement in Long-Term Services in Sports. And that institute is run through a partnership between the state Medicaid agency, the Tennessee Department of Labor, and the Medicaid managed care plans. It's based on an apprenticeship model where new DSPs are supervised by trained DSPs receiving training while working. And as the workers gain skills, their hourly wage increases incrementally. And in addition to the required training for all workers, those who stay in the career long-term have opportunities for additional learning and advancement. Next slide. Finally, states are also undertaking specific strategies for recruiting new workers, such as through pipeline programs and publicity campaigns, and retaining their existing workforce by addressing other sources of worker dissatisfaction. For example, several Arizona managed care organizations worked with PHI to disseminate a survey and identified several barriers to workforce retention, including inadequate supervision, need for advancement opportunities, and lack of continued training. So one retention approach is building a workforce culture that involves supervision and peers to support workers and offer mentorship. Peer matching programs can help combat the isolation some workers feel and help workers address on-the-job problems. Additionally, states like Washington are working on supportive supervision programs so that workers feel supported at work and know how to report issues or ask for assistance. Another factor in worker retention is finding a good worker-client match. Factors such as their desired hours, language spoken, and location affect workers' experiences and beneficiaries' care. States can provide tools to support workers and beneficiaries in finding a good match. 10 states have matching registries, but most are nonprofit run, with only 3 registries being run by states. As one example, Minnesota created Direct Support Connect, which is a statewide job board where workers and beneficiaries can create detailed profiles and search for potential matches. To recruit more workers, some states are developing pipelines to the HCBS workforce for high school and college students. Arizona, for example, recruits workers through a training program at career and technical high schools, where high school students can earn credit while also completing the state's required training program. So in conclusion, I just want to share that we are currently developing an issue brief, which includes much of the information I shared today, and we expect to publish that brief on our website in the next few months. So next slide, please. I guess I can stop for any questions before I go through just our last few slides here. Okay, seeing none, I will continue, and then we'll certainly open it up for questions at the end. So Kristal, if you can go forward 2 slides, please. Okay. So this slide lists a few other current projects that we have underway. We received a mandate in the Consolidated Appropriations Act of 2021 to examine the settings available to individuals in the Money Follows the Person program, and particularly how they differ from the HCBS settings rule, and to consider if there should be alignment between these 2 sets of requirements. So there will be a chapter in our March 2022 report to Congress on this topic, weighing the arguments for and against alignment. However, our commission is not making a recommendation one way or the other. Another project currently underway is considering what designing a core HCBS benefit might entail and what the key considerations of creating a mandatory benefit are. A roundtable was held last month, and we plan to share the takeaways from that discussion this spring. And finally, MACPAC staff are also studying presumptive eligibility for HCBS and conducting stakeholder interviews on how it has been used and what barriers to state adoption are. Next slide, please. So this slide is a resource for how you can stay up to date with MACPAC. You can join our mailing list. Please follow us on Twitter and LinkedIn, and feel free to attend our public meetings and provide public comment. Our January meeting will be held on the 20th and 21st, and the agenda and link will be posted on our website shortly. We have not yet made the decision whether to continue with virtual meetings or go back to in-person for the remainder of our spring sessions, but we anticipate providing opportunities for continued engagement when we do resume in-person meetings. And of course, please feel free to continue to reach out to Kristal and myself, as well as other staff as appropriate. You can find our full staff list and contact information on our website. And the last slide, please, is just some links to a few of the resources that Kristal and I have mentioned today. And there's also a lot of additional information that you can find on our website as well. And so with that, I will just thank you again for inviting us to share a bit about MACPAC and some of our recent and current work. And Kristal and I are happy to take questions at this time.
Okay, have you found any states that have successfully dealt with the workforce shortage? We're finding that's driving some of the staff burnout, the lack of supervision, because supervisors are having to take over direct service slots, and therefore they're unavailable for the rest of their staff as far as supervisor support. And it seems to be across the board on our agencies. The workforce shortage is just creating a large number of problems, even though some of the rates have gone up and some of the salaries have gone up.
Yes, absolutely. I think that's entirely correct. You know, I think every state is facing shortages, so I don't think that there's a particular state or a particular area where we can point to that we can say there's not a shortage there. I think it's really just the different strategies that states are trying to employ to help ameliorate some of those shortages.
Okay, if you find any best practices, let us know.
Okay, yeah, and there'll be some more detail in the issue brief that I mentioned that we'll be publishing in the next few months.
I'd also mention, and I'll pass the link along to Jody on this one as well, Advancing States, which is the Association of state LTSS directors, has compiled some information on what states are going to be using their, or what they at least plan at this moment to use their ARPA funds on. And so they have some tables with, workforce being one of them, the areas that states, almost every state has some plan to focus on. So the plans themselves are pretty, they vary a lot, but it's a nice resource that kind of gives you at a glance of which states plan to focus on a couple of different strategies. So for example, some states plan to use funds for things like recruitment bonuses, retention, like actually increasing wages, training programs. So that would be something you could just take a look at what different states are doing. And we've started to kind of talking to different states, and we had a session with a number of states recently. And when we asked who was focused on workforce, everyone raised their hand. So it's a place where pretty much every state understands that that's a challenge and are trying to find ways to address it.
Sure. Thank you.
I had another question. When you, Kristal, when you very first started your presentation, you indicated that there were 17 commissioners that are appointed for 3-year terms. Is the list of those commissioners on your website somewhere? And I'm just curious if you know in particular if there's a consumer or stakeholder ratio of people who might be listed or chosen as commissioners.
Sure. So just to give you a little bit of background, we're actually, our call for new commissioners is out right now. It's the commissioners are appointed by the GAO, and so they manage that process, but they put a notice out in the Federal Register about a week ago. We've got a number of commissioners that will be rolling off. They're typically able to be reappointed once. So while they're at 3-year terms, a lot of them end up serving for 6 years. But we have a number of commissioners who are in their second term. And so we're expecting to have, 3 or 4, I think, positions that will be open this year. And in terms of Tamara's dropped in the commission list into the website, into the chat box. In terms of consumer representatives, we actually have a commissioner who just joined us this year, Dennis Heafy. He's from Massachusetts, and he is a consumer representative. He's a self-advocate and a long-term advocate, and brings a great perspective, to the commission. And we have, typically have at least one person who serves as a consumer advocate, in addition to, a number of other commissioners who come from like advocacy backgrounds as well. So.
I was sure that was the case. I just would like to see the list. Thank you.
Sure. And another thing we also try to do just in all of the work, as we talked about some of our projects and who we speak to, is make sure that we reach out to advocacy groups as often as we can, consumers themselves, in order to get their perspectives on different issues. So it's really important. And Tamara's also dropped in the chat the link to the Advancing States analysis. That is a great resource. So. Any other questions?
And the information for the public meetings, you said there's one coming up this January. Is that on the website as well if folks are interested in participating?
So yes, so our meetings next Thursday and Friday for this next session, things that might be of interest. We do the agenda, the final agenda should be up later this week, but I believe Friday is when I'll be presenting on the money files to person mandate. And again, it's looking at pretty focused on settings that qualify for money files to person and sort of how they compare to settings that qualify for HCBS payment under the settings rule. And so we'll be discussing that on Friday. And for people who are interested in issues around dually eligible beneficiaries, we're also, we'll have some discussions there during the meeting, as that's a high priority area for the commission as well. But we have a number of things that, one of the last slides talked about some of our upcoming work. We've got a pretty good and growing group focused on LTSS right now, as also behavioral health. And I should mention that we will be having some work over the next cycle around behavioral health issues for people with IDD or also HCBS for behavioral health, people with behavioral health needs. So those are issues that we're really interested in and trying to understand more about. So we're also really interested, maybe if there are no other questions, in hearing a little bit from you all about what you might be interested in as we're work planning and thinking about what kind of resources are helpful to the policy community. It's always helpful to know what people are looking for. So it sounds like workforce is one place for sure that is a priority, but we'd be curious to hear about any others as well. So.
Well, hearing then, maybe we can have, since we have that line of communication, if folks think of something or if something comes up, then we can reach out either through me or directly to Kristal or Tamara, if that works, And I'd like to, we have a newsletter that comes out as well on a monthly basis. So, we can be sure to highlight anything that's relevant to our membership that's coming out, either whether it's issue briefs or information like that, feel free to send it my way, but I'll also check your website out periodically to make sure that we're not missing anything and so that we can keep our membership informed too.
Great. Well, thank you. And as Tamara also added in some information on our website. You can find our email addresses there as well. So feel free to reach out with any questions in the future. So thanks.
Well, thank you both so much for joining us today. We really appreciate it. And again, we'll be in touch, and that's it. So thank you.
Great. All right. Thanks. Take care, everyone.
Take care. Bye-bye.
Bye.
Thank you.